colleagues, thanks for joining this symposium sponsored by FRESENIUS Medical Care on anticoagulation in CRRT, the state of the art in 2020. We have the pleasure to have Professor Dimitro Chardinov from Germany, Department of Intensive Medicine and Nephrology at Charité in Berlin, and Professor Antoine Schneider from Lausanne University Hospital, the Service of Intensive Medicine. We will start directly with Professor Antoine Schneider, which will speak about the procoagulant state in patients with COVID-19 and the need to adjust anticoagulation in CRRT. So, Antoine, thank you for joining this symposium, and can you please share your slides and present for us?
Yes, thank you very much, Claudio, for the kind introduction. Thank you, FRESENIUS, for the opportunity to speak at this event. And indeed, we will discuss procoagulant state and the complications happening during continuous renal replacement therapy. So as been alluded throughout this conference, of course, AKI is common in patients with COVID-19. It's a marker of severity and negative prognostic factor, and a large proportion of these patients require, those admitted to the ICU at least, require renal replacement therapy. And in this very nice cartoon proposed by our chairman in a recent review in the Lancet Respiratory Medicine, the relationship between SARS-CoV-2 and acute kidney injury is quite not fully understood, but there's some ideas of how it happens. And there's definitely a direct toxicity from the virus. We've been able to show some inclusions of the virus inside the different parts of the kidney. There's the inflammation that definitely plays a role. There is some hemodynamic and mechanisms of care that are probably altering the renal function as well. But what we're going to focus today is the issue of coagulopathy. That is also an important component of the progenesis of acute kidney injury. So this coagulopathy is multifactorial, and there is all different processes leading to activated coagulation, fibrinolytic suppression, and there's endothelial damage leading to thrombosis, platelets activation and aggregation. All this will lead to clotting. These clottings will be observed in the venous part of the circulation. The recent publication have suggested that an incidence close to 20% of the patient might have some form of venous thrombosis, but also in the arterial part of the circulation, leading to stroke, myocardial infarction, and so on. So arterial thrombosis might be also very important. In addition to that, it's still unclear, but there appears to be a thrombosis as well in the microcirculation, leading to further complication and potentially contributing to the pulmonary issues and definitely contributing to the AKI. So we know that we need to, we should be increasing the prophylaxis administered to our patients, whether you use enoxaparin or heparin, increase the frequency, not quite to a full intensity therapeutic dose, but rather to the intermediate intensity dose. But then, what about CRT? We know CRT is administered frequently to this patient. We know clotting is a problem during CRT under normal conditions because of the blood surface contact, the mechanical compression at the blood pump, the low blood flow, the prolonged treatment, and so on. But of course, if you add to these issues the procoagulant state that is encountered with COVID-19, then the risk of clotting is further increased. And clotting actually needs to be differentiated from clogging, but these two processes are probably connected. The clotting is when the flow is impaired within the membrane. There's a clot stopping the blood flow, and the clotting and when there's a deposit of a protein cake together with red blood cells lining and decreasing the permeability of the membrane. Both these phenomenons are thought to be increased during COVID in COVID-19. So these two phenomena can be observed through the different systems and the different alarms in the CRT machine. Essentially, pressure drop or increase of the delta pressure, suggesting of clotting, and the clogging will be associated with a TMP rise. But mostly, if we do regional citrate anticoagulation, we should suspect it when we decrease the need for calcium substitution. Metabolic alkalosis, suggesting really a decrease in the efficacy of the therapy. The citrate is not dialyzed, so it returns to the patient. Why is that important? Obviously, because if we are in a period of such as the COVID outbreak, these issues of clotting and clotting will lead to decreased renal replacement therapy quality, lower efficacy. It will generate alarms which the nurse have to deal with, and will eventually lead to early filter failure, decrease the filter life, increase the nurse of the workload, and eventually the cost. So this is all particularly important in the outbreak, in the COVID outbreak period, because these resources are limited. We might be lacking filters, we might be lacking machines, and most importantly, we're lacking manpower. So what can we do? Under normal circumstances, we use systemic, or we used to use systemic anticoagulation, heparin, low molecular weight heparins, etc. Of course, this is now progressively losing credit and becoming less and less in fashion because of the risk of bleeding, because we know then this therapy needs to be suspended for procedures, and we often give inadequate dose of this medication to actually prolong filter life, and the filter life is poor. So now increasingly we tend to use regional anticoagulation, mostly based on citrate, but there's alternative, but the most commonly used is citrate. And the idea is here you have no risk of bleeding, you have a much better filter life, and therefore the circuit permeability can be higher, there's less clogging, and therefore the efficacy of the dialysis process is higher. Unfortunately, there's a little bit of a learning curve, so citrate needs to be adopted, and there's training to be undertaken by the teams. But still, my first tip to practically approach CRT for COVID-19 and to use the anticoagulation would be to use citrate anticoagulation. The next speaker will explain to you in further details, but it's clear that at least the filter life, it's much longer if you use citrate versus heparin or any other form of anticoagulation. And there's a very recent paper published last week that was aiming to compare survival between a randomized control trial, comparing survival between patients who receive citrate anticoagulation versus systemic. It failed to demonstrate, it was underpowered to demonstrate a mortality signal. However, again, it was very clear, and you can see on the right part of the screen, the almost double median filter life when citrate is used. So clearly, citrate is the way to go if you're used to it. But there's other option that you can combine with citrate or add if you are not familiar with citrate in your unit. And the next one will be to use diffusive modality, or at least to minimize the ultrafiltration part of the therapy that you use. Clearly, hemofiltration, so pure CVVH, is associated with, by definition, hemoconcentration process, because you remove fluid by the filtration process. Obviously, you're replacing this fluid at the end, but still within the fiber, the membrane, there is some concentration that is happening, leading to coagulation and increasing the coagulation. This can be minimized by the use of pre-dilution, but it really needs to be accounted for. So when you do CVVH, you must be really careful that you have a sufficient blood flow to keep the filtration fraction under 20%. This is sometimes problematic, especially for hypovolemic patient. In CVVHD mode, this is never an issue because by definition, you do no or very, very minimum filtration only for fluid removal. So citrate anticoagulation, CVVHD, and then when the coagulation is not the main issue, but the clogging is the issue, this can be observed in patients that are very inflammatory, and of course with COVID-19 we see that very often, there is the option to use these membranes with a higher cutoff. And there's been observations that the higher cutoff are less prone to clogging. This data here shows that the clearance of the molecules and even the large size molecules are similar or higher than that with the conventional membrane. And here we're talking about the MIC2 from FRESENIUS, which has a very high cutoff and might be considered in patients that are clogging their filter very precociously. So then clogging, you can use high cutoff membrane. And the last thing and the best anticoagulant should not be forgotten, the vascular access. Obviously, this is the most important component of the RT circuit. If you want to save your circuits, you need to have a very good vascular access. Identify the issues that are related to the vascular access and replace it as soon as you can. So the recommendation is to use a large with the right design, shown here, the kidney shape with the right tip, in order to minimize circulation. And mostly the position should be in a large vessel, a central vein, the tip of the vessel, and really test the catheter, make sure this is all right. When some patients for those patients that are in ECMO, and again, during COVID, we might encounter some of those, particular venous ECMO, this might be seen as the ideal catheter because obviously there's no issues of flow because there's very high flow within the ECMO. So venous ECMO, the CRRT machine can be connected through different variants. Make sure you are fine with your perfusionist, that you know how to do it. You have a strategy when the filter is clotted, how to replace the machine. This is not trivial. There might be very severe bleeding, so this needs to be considered, but done with lots of care. So that brings me to my conclusion. I think in situations of limited resources, it's capital to optimize all therapy, everything we do, but CRT in particular, because this is a very common procedure requiring lots of workload from the nursing staff and lots of resources. And the recommendations that I can provide is to use regional citrate anticoagulation as much as possible, to favor the diffusive mode and CVVHD mode as a first choice modality. Make sure you have adequate vascular access and replace it if you are unsure or if there's an issue with that rather sooner than later, and consider the use of high cutoff filter if you have membrane clotting issues. Thank you very much.
So thank you very much, Antoine, and thank you for the nice view of Lausanne and your hospital, which looks great. I have the privilege of being the chairman of this session, and therefore I would like to ask you a couple of questions. The first question is, do you think that while we're doing citrate anticoagulation for CRRT in COVID patients, there should be an additional systemic treatment with low molecular weight heparin, or do you think that this will be sufficient to provide also a systemic treatment?
No, I think what I like about regional anticoagulation is that we decouple in a way the patient from the machine. So the citrate is providing anticoagulation for the circuit, and we can switch it on or off according to the issues. But then we still, of course, need to provide a systemic anticoagulation, so prophylactic or therapeutic if, for instance, the patient has a pulmonary embolism. The anticoagulation, I don't think also, some people might say, okay, the patient has systemic anticoagulation, so we don't need to anticoagulate the circuit and we don't need to use citrate. I'm not convinced, because I think the systemic anticoagulation in most patients is not really effective in the therapeutic range, 24 hours per day, 7 days a week in an ICU patient, for the reasons I mentioned during the presentation. The patient has to return to theater, or to have a procedure performed, and I think in this patient we tend to stop the heparinization, the circuit run, and we forget there's no anticoagulation, then the circuit will clot much earlier.
In case we decide to treat the patient with special membranes, for example, MIC2 membrane, which has a high cutoff characteristics, do you recommend any specific modification of the citrate management of the circuit?
No, I don't think the clearance of citrate is really increased by the high cutoff, because citrate is a very small molecule, so it's very the sieving coefficient is close to 1. So I think it's the limiting factor will be the dialysate rate anyway. So I don't think the type of membrane should change the removal of citrate, and therefore the protocol I don't think should be adapted.
Is there any specific patient in which you would consider a contraindication for use of citrate?
Well, I would say, I would turn the question and say, I think there's probably some centers that are not used to using citrate. We started using citrate for all our patients now 7 years ago in 2013. And at the beginning, we had contraindications. And we thought patients that are in circulatory shock with lots of noradrenaline, high lactate, those patients with severe liver failure, we felt that we were uncomfortable doing citrate for those. And progressively, as the team became more familiar with citrate, and as we also, the literature showed us that there was safety to provide citrate for liver patients, and we become more and more comfortable. And now we've shifted to giving or using citrate anticoagulation to all patients, but being aware that yes, there might be complications. There might be some patients for which they need to be special care. We follow the total of ionized calcium very regularly, and if we feel the things are not going, there's some form of the total of ionized calcium is going up, or the situation of the patient is deteriorating, we might consider switching back to heparin. But again, this is in very small number of situations. However, sorry, one more thing is about the center. And again, we moved to this very cautious approach. And I think those centers that have not been, that are not used to using citrate should have a very conservative approach as well.
One last question. You mentioned clogging, not clotting, but clogging of the membrane in case of protein adhesion at the blood membrane interface. In light of this and the importance of clearance of middle large molecules in COVID patients, do you recommend changing the filter more frequently compared to other patients?
I think the truth is we don't have data on this. I mean, we know that for normal patient, the clearance with regional citrate anticoagulation, as far as I know, I don't know that if we have really good data on even non-COVID patients showing really that the clearance is really stable with citrate. I know that for the high cutoff membranes, actually we are currently doing a study here in my center, trying to establish whether the clearance of small and middle molecules are stable at 24, 48, 72 hours. Again, this is not for COVID patients. We might, because what's happening now, we're able to include some COVID patient, and maybe we can have data to really support that. But
in the past, we generated some data showing that after 24 hours, there is a decay of the permeability of the membranes.
But if I'm not mistaken, this was not in CVVHD mode, was it?
We did it in CVVH, actually, and CVVHDF. Nevertheless, I think that clogging is only in part related to filtration fraction. The other part may be simply related by the interaction between proteins and the membrane. So I think it's something that we should study. Well, with this, I thank you very much for joining this symposium. And we are looking forward to the presentation of Dmitro Chaplinov from Department of Intensive Medicine and Nephrology at the Charité Hospital and University in Berlin. Thank you very much, Antoine, and let's proceed to the next step.
Hello, ladies and gentlemen, dear colleagues, dear chair, thank you very much for the invitation and possibility to present my talk today. I'm going to talk about citrates versus heparin anticoagulation in terms of CRRT, what to recommend. I would like to start with this slide that represents the way we have done throughout our research. First reports of original citrate anticoagulation are from 1990 from Professor Mehta, where he used it for continuous arteriovenous hemodialysis. And it took us almost 20 years to come where we are just right now. And so we started with the quite simple devices with external pumps. And now we have a sophisticated machines with quite sophisticated software, integrated citrate and calcium pumps, and a protocol which allows us strict action, a strict reaction on any metabolic complication, and to allows us to give a tailored treatment for patients. What the guideline says about the anticoagulation for the patient on the continuous renal replacement therapy, unfortunately, the guidelines are not that up to date. They are quite old, but nevertheless, they say that patient without an increased bleeding risk, because if bleeding risk is increased, your choice should be obvious, or impaired coagulation and not already receiving effective systemic anticoagulation, should be anticoagulated with regional citrate anticoagulation, except they have a contraindication for citrate. We will talk about the contraindication a little bit later. But to sum up, I would say that regional citrate anticoagulation should be seen as a standard care for CRRT. And why is it so? Because citrate is safe, first of all. It is shown in this slide from the meta-analysis from Bai et al., published in Intensive Care Medicine 2015, analyzing 9 randomized control trials, that the patient with regional citrate anticoagulation have significantly less bleeding risk. And this is noteworthy that those patients with increased bleeding risk were excluded from those randomized control trials. So it makes this finding even more important and significant. Why citrate is preferable? Because it is effective. And in terms of filter lifespan, of course. And if first meta-analysis wasn't that persuasive from 2012, the further meta-analysis from 2015 from already mentioned Dr. Bai showed that regional citrate anticoagulation is significantly better in terms of filter lifespan. And last meta-analysis analyzing 10 randomized control trials showed that regional citrate anticoagulation is more effective regardless of modality used, CVVH or CVVHDF, regardless of pre-dilution or post-dilution. And last but not least, I cannot allow myself not to mention the latest randomized control trial from Dr. Zarbuk, published in JAMA just for a week ago. It has been performed in Germany in 26 centers and analyzed the effect of regional citrate anticoagulation versus systemic heparin on the dialysis filter lifespan and mortality among patients with AKI and treated with CRRT. It recruited about 600 patients, and the most important finding of the study was that regional citrate anticoagulation in this one of the biggest randomized control trial was significantly higher than the systemic anticoagulation with heparin. Unfortunately, due to recruitment problems, the study has to be stopped before it has reached planned numbers of patients. So for the second outcome, 90 days all-cause mortality, it was underpowered and wasn't able to show a significant difference in this outcome. Nevertheless, the study agree with previous reports and gives us more evidence. So now let's talk about those patients who have contraindications for citrate. What are the contraindications? And the guideline says that major contraindications for the citrate anticoagulation is severe or are severely impaired liver function or shock with muscle hyperperfusion, both states, representing a risk for citrate accumulation. This guideline is a little bit up to date, and there is a robust evidence contradicting those statements. Nevertheless, I will try to explain why. What means the contraindication for citrate and how does it happen? Well, regardless of the protocol, citrate will be infused in arterial line, and citrate chelates calcium. Calcium citrate complexes will be removed with the effluents, and significant amount, it depends on the protocol you use, CVVHD, CVVHDF, or CVVH, significant amount of the citrate complexes, calcium citrate complexes will be infused in the patient, but it's not the problem in the usual metabolic state of the human being. Citrate will be metabolized to 3 molecules of bicarbonate, and it will serve as additional buffer, and calcium will be released and used as ionized calcium, excuse me. And in cases when the ability of the human being to metabolize the citrate is compromised, the accumulation of citrate has happened. And how come and what is it? Is explained in this very well written review published by Dr. Snyder, who is the next speaker, and I highly recommend you to read this review. He said that the ability of the human body to metabolize the citrate is a dynamic process, and this threshold is not stable. So in a normal situation, normal state, where the hypoperfusion is not present, the threshold for the citrate metabolization is quite high, and in terms of shock or severe liver failure, this threshold is reduced, and it could happen in the same patient. But first of all, let us talk about how high is the incidence of citrate accumulation. In our retrospective analysis from our center, we investigated more than 1,000 patients treated with CRRT along 3 years of an investigation period, and we found out that only 32 patients had signs of citrate accumulation over the time of the treatment, which is fairly low. So again, about the contraindications stated in the guideline, the liver failure is one of them, and is it a contraindication per se? And the answer is no. I'm very happy that this meta-analysis of the studies has been published 2019, where colleagues analyzed 10 studies with mostly observational character, and they found out that regional citrate anticoagulation during CRRT did not significantly increase the risk of citrate accumulation in patients with liver dysfunction. Moreover, the acid-base status trend from acidotic towards alkaline. The calcium disarrangement was similar between the start and the end of the therapy, and the liver failure patient had comparable pH, lactate, and calcium levels during RCR-CRRT. And last but not least, the filter lifespan of RCR-CRRT was significantly prolonged. So the answer is no, liver failure is not a contraindication per se. What about the shock with a hyperperfusion? Indeed, pathophysiologically it makes sense. In our retrospective analysis, we found out that all the patients with citrate accumulation had also hyperlactatemia at the time of the diagnosis, which is logically because citrate metabolism or citric acid cycle is oxygen dependent, and in terms of hyperperfusion shock, it is rather anaerobic state. So the lactate concentration are getting higher and could be lactate could be seen as surrogate parameter for as a risk factor for the citrate accumulation. So we took further look on those patients and tried to stratify the patient to the lactate levels at the very beginning of the CRRT. And we have found out that the patient with a normal lactate level did develop a citrate accumulation in the further therapy treatment, but the incidence was mostly neglectable. And with the higher lactate at the time of the therapy initiation, the incidence of citrate accumulation was indeed higher. But even in patients with a severe hyperlactatemia of more than 4 millimole per liter, the incidence of citrate accumulation was not that high, reaching the 6%. We took a further look on the time course, and we stratified the patient to the severe and non-severe hyperlactatemia at the time of the treatment. We found out that the patient with initially rather low lactate levels, who did not develop a higher lactate concentration over the time of the treatment, also did not develop a citrate accumulation. But the patient with increasing lactate levels over the treatment, risk for citrate accumulation was very high. The same was about the patient with initially severe hyperlactatemia. Those patients with a positive lactate clearance, where the lactate decrease was significant, were not at risk for the development of citrate accumulation, but the patient with persistently high lactate levels over the time of the treatment were accumulating citrate. So increasing or not decreasing lactate concentration over the time should be seen, rather than initial lactate concentration, should be seen as a predictor for citrate accumulation. I would like to sum up and to give you a take-home message from our nearly 30 years experience with regional citrate accumulation during CRRT. CRRT provides excellent safety, metabolic control, and excellent filter lifetime. The incidence of citrate accumulation is rather low and could be well addressed by careful monitoring and timely strategy adjusting. The liver failure patients, liver dysfunction alone should not be seen as the contraindication per se, but those patients do require intensive monitoring of acid-base status and calcium parameters. And not only those patients, but patients with the shock do require the more intensive monitoring. And high and especially increasing lactate levels should be seen as a predictor for citrate accumulation. Thank you very much for your attention, and I would be happy to answer your question. Thank you.